Hello, Ross Davenport, a trauma and vascular surgeon. My practice is at the Royal London Major Trauma Centre in London, UK. Interestingly, Europe has never actually had its own vascular trauma guidelines. There are clearly lots of international guidelines, particularly from the US, from both trauma and vascular societies who have written numerous guidelines over the years. There are some individual nations that have some recommendations for how certain things should be managed. But this is actually the first comprehensive vascular trauma guideline for all of Europe. And as we know, injury patterns differ across the world, trauma systems differ, and how individual vascular practice differs based on unit-to-unit variation. And so we saw, within the Vascular Society across Europe, an opportunity to bring all of this together, to reappraise the evidence that's out there, because there has been a lot that's changed over the last 10 or 15 years, and to make something that was relevant for our practice in Europe, such that people could then take this away to their own countries, to their own institutions, to their own societies. There's actually over 100 recommendations, but they are really grouped around some particular themes. And time has come out as a particular difference to what our vascular community would have thought about in terms of how extremity vascular injury should be managed and the safe time window to extremity revascularization. The evidence is actually very clear from a number of high quality publications that have shown there is no safe window. If you have traumatic ischemia, then you have to revascularize as soon as possible. This is completely at odds with what we are taught, over many years around, 6 hours is probably a safe window. And that's completely different in trauma. And so the recommendations are very strong in terms of rapid diagnosis and rapid revascularization for ischemic limbs. The issues around endovascular was difficult actually, because whilst clearly vascular surgery is moving very much towards endovascular intervention, trauma struggles with this a bit because of the multiple injuries that may be having competing priorities for the patient. How you diagnose these patients quickly is generally going to be with CT scanning. But where endovascular fits into this and the evidence base for this was challenging. And so there isn't actually much in the way of recommendations. Clearly, when you're talking about endovascular and trauma, you cannot not talk about REBOA, so endovascular resuscitation, balloon occlusion of the aorta. And there was one dominant thing in here, which was the UK REBOA trial, which was one trial. There are lots of things that have been talked about the trial and its relevance to other systems, and clearly a device that's actually quite old. And there has been lots of newer devices that have come on and different practices. So for me, vascular, or endovascular rather, in this space is very much in the infancy. I think we will see, changes to that particular indication and that recommendation coming online very soon. The third part for the guidelines, which crossed all body regions, was the evidence base behind venous grafts versus synthetic grafts. And as vascular surgeons, we've all grown up being taught that venous grafts are better, they're more durable, they are used in all vascular pathologies. But in trauma, there's a difference here because of the time element, as I said in the beginning, is so important, and the time you can reestablish flow is absolutely vital to good outcomes for the patient and limb salvage. And the evidence base really is not there to say that venous grafts are any better than prosthetic grafts in vascular injuries. And so this is going to take a long time, I think, for this community of vascular surgeons and practitioners to come on board with this. And clearly we need some more evidence base to confirm this. But certainly, there's a strong recommendation that bridges all of the elements of the guidelines that there is no additional benefit to harvesting vein in terms of good outcomes for your patient. And this is, suggesting that we should be using much more interposition grafts, short interposition grafts, rather than long bypasses, and that prosthetic graft is just as good as venous grafting. First of all, read the guideline, but also read the guideline in the context of your own practice, your institution's practice, and whatever societies you're involved in your own host nations. These guidelines have had huge impact for us in the UK in terms of changing recommendations in the Vascular Society, but also other specialties. If we look at knee dislocation, for example, clearly it's an orthopedic and a vascular pathology, very common, and yet still we are losing limbs needlessly. And so understanding how you work together with different societies to implement these guidelines, and this is work in progress for the UK, there's work at how we mesh the orthopedic practice, the plastic practice and vascular to actually bring these guidelines to life and actually change what we are saying on a national level with key performance indicators and actually hold us to account to say this is the evidence, this is what we should do, so we actually move the field of vascular trauma further forward.